And so what we'd like to do now is, for the next, we have about 15 minutes before we break for lunch. And so we'd like to give everybody the opportunity. We didn't have questions after each one of the talks, but we'd really like to open up the floor. And any questions that people want to ask from any of the speakers, please. That was your entertainment for this afternoon. Thank you very much. So please feel free to ask any questions at all. And I think a sort of key point that you should really take from this morning's session is that there are just multiple options and opportunities. And this is exactly where, I think we should be, where you have choices to make, and you can select any one of these that you find as a preference. So, questions? And we have 2 microphones, and they'll run them over to you because there's no way we can actually hear people all the way to the end.
This question is for Dr. Ney. Am I saying the name right?
Yeah.
The question is, what, if any, are the benefits or risks of having, I'm going to try this, increased threonine and isoleucine in the body? Are there added benefits or are there risks of having that increase?
Do you want me to come in there?
Yeah, that'd actually probably be easiest.
The question is, what are the benefits or risks to having elevated levels of threonine and isoleucine after eating GMP, correct?
Yes.
Yes. Very good question. There has been a tremendous amount of research that has been done regarding amino acid metabolism. And when I first started in GMP, this is the first thing I did. I went to the literature and I looked to see, is there going to be a problem with having elevated levels of threonine and isoleucine? And the answer to that is no. These are non-toxic amino acids that have been well studied in the literature. And we observed that after 4 days, the levels of threonine in blood plateaued, okay, between 3 and 4 days, so they weren't going any higher. I would also say that there is quite a bit of safety data available in humans for consumption of whey, and the best example of that would be infant formulas, which are predominantly whey-based formulas and thus have a lot of GMP in it. And we know that babies without PKU fed standard infant formulas have elevated levels of threonine and isoleucine. So it's within a safe range. Thank you.
So what happens to the excess levels? Does the body use that or is it excreted?
Well, the body can degrade threonine and isoleucine, unlike phenylalanine. And so, they are degraded with time. But the level, if you were on a GMP diet, your levels of those amino acids would be higher than if you weren't consuming GMP. There's no question about that. But we think the benefit is that those higher levels for someone with PKU will compete, the threonine and the isoleucine will compete with phenylalanine and reduce phenylalanine transport into the brain. So that's the biggest benefit.
Thank you.
You're welcome.
I can talk loud.
I'll repeat your question if you'd like.
I have to say, we are so excited by GMP, and I just want to say thank you so much for what you've done and what Campbell has done. My first question is, looking at the time frame that you're looking at, the way the body breaks down the amino acid, how it spikes and then plummets, and the natural protein kind of goes across, and the potential of GMP to possibly lower blood-feed levels. I know it's lowering the blood-brain or even the blood-feed. Could it be because it's in the body longer, that the body has more time and it has its more stabilizing abilities? Kind of like in some ways the myth that the body has more time there to break down the phenylalanine to the tyrosine. Is that a possibility? And secondly, when is this going to be available? Molly's waiting.
Okay. I'm going to let David answer the when will GMP products be available, but let me take your first question. And that you were asking if GMP, because the amino acids are in the body for a longer period of time, will lower phenylalanine levels, sort of like Kuvan. And the answer to that is yes. We believe that a GMP diet over time will lower blood phenylalanine levels, but the way it's working is completely different from Kuvan. Completely different. Okay. Kuvan, you're stabilizing that enzyme. We're not doing anything to the enzyme. We believe, and we will test this in our clinical trial, hopefully, we believe that blood phenylalanine levels will be lower when you're eating GMP because you will have a longer stabilization of amino acid levels in blood, unlike that sharp spike with amino acid formula. And that will promote insulin, that will promote protein synthesis. That will also be facilitated by the higher insulin levels with GMP, and there's sort of another interesting story that GMP actually promotes insulin secretion, and it has potential use in diabetes. Okay, so the mechanism for lower blood Phe levels with GMP is improved protein synthesis throughout the day. And remember, with Phe, it only has one place it can go out of the blood, and that's to go into protein. And so if you're making protein, the Phe is going into it, the Phe is coming out of the blood. Otherwise, the Phe is accumulating in the blood, some is excreted in the urine, it's being transformed into organic acids and other things. Does that answer it? Thanks. Now, the when question.
Well, the good news is that our first GMP product, which we call Better Milk, is going to be available by February 1st. We've completed all our testing and have NDC numbers, et cetera. Some of the other products that we would love to bring to market right away, such as snack bars, the Whey Crisps, a variety of other formats, are possible for us to manufacture, but we face some of the challenges with regard to insurance reimbursement. We heard Jeff Lewis talk this morning about a need for advocacy here in this group, because we face every day the challenge of having our foods that are protein supplements tied up in various types of legislation and whatnot. So I think what we are looking to do is to bring this product to market and make sure that we can get reimbursed for all of you so that you can continue and we can continue developing them in many more formats. Part of our challenge as Cambric Foods is that my two children with PKU wrestle with the diet every day, and the thing that we would like to see is to make put the protein back in the meal, in essence, and make it less like a medicine. So while we laud the efforts for the other alternative therapeutics that are more medicinal, we also look at the one that is working for us now as an effective therapy and try to make that more like food. So as you write to your congressman, sort of emphasize the fact that there's some value in expanding the food coverage.
Great. We have a question right over.
Wait, it's in response to.
I just have a question about the makeup of the GMP products, the Better Milk from Cambric. This came up from the presentation, I think it was the pudding. It said that it had 5 grams of protein to the 15 milligrams of Phe. Right now, without any alternative treatment, I'm working with a really, really limited Phe tolerance. So I'm wondering, with the Better Milk of those products, what of my Phe, I'm working at 150 milligrams, is going to be taken up by the formula, which right now isn't providing any of that or taking away any of my Phe tolerance. And with the lower blood levels, it's kind of on both of the responses to that. Is it too early to think, with a lower blood Phe, you think maybe there's going to be a higher Phe tolerance? Are you expecting that long term?
It's possible with the GMP that we will have a little bit of a higher phenylalanine tolerance, but we don't know that now. I'm just speculating. In our clinical study, we had people that only tolerated 250 to 300 milligrams of Phe a day, and we were able to put GMP into their diet with 2 milligrams of Phe per gram of GMP. It was possible to do. But I certainly appreciate your concern that, unlike the amino acid formula, it's not phenylalanine free. And until we know more, we have to count the Phe in GMP within the total phenylalanine allowance. With more information, we may be able to liberalize, but we don't know that now. Okay.
My
Right.
questions, I have 4, actually, for Catherine Mosley regarding the large neutral amino acids. You said that there are 4 products that are being used in the United States. At what age, what's the youngest age that are children using these, or is it mostly adults or teens using it?
Our youngest was 13 because she would not comply to the diet and was having lots of trouble in school. And once we started the large neutral amino acid therapy, got a call from the teachers, what is happening? But because she was starting to do much better, concentration much better. But you have to understand, with any kind of a therapy, with the diet, she was taking the tablets, and the tablets are dosed by weight, and there is a limit. But the typical dose is 10 tablets 3 times a day with meals. And you take it with regular food, and you can have even a little bit of meat. But like any other diet, if they're non-compliant with the formulas, there's also the risk they're going to be non-compliant with the large neutral amino acid therapy. So she did fine for a while, and then she started being non-compliant with that, but then now she's come around again. So it's difficult. But our youngest was 13. It's usually offered, teenagers when they're not taking the formula, because the formula does the same thing. You're taking the formula, you're getting the large neutral amino acids. But if they're not going to comply with and take the formula and eat the low protein products, then you have a real problem because they have to take something. So it's usually offered around 15, 16, and then the adults. We haven't had any small kids on it.
So we probably have time for 2 more questions for lunch. So if you'd like to ask, I know you had a list, so if you can ask one more of yours, and then we got one right here.
My other question was the risk regarding women of childbearing age, because the blood phenylalanine levels can still be elevated throughout the rest of the body. Would that be something?
Well, definitely if you're planning a pregnancy, no. And Dr. Koch and I used to have this argument all the time because it has not been tested in maternal PKU, and your blood Phe levels are higher. But my argument was I'd rather have them be on the large neutral amino acid therapy than nothing. So that's the deal.
All right, we have one more question right over here.
I'm not really sure who is going to answer this, but in my family, we have diabetes. And when I think about the PKU diet, I think about carbohydrates and sugar. And I'm wondering if there's been any test that diabetes is affected or could be affected by the PKU diet, and that if exercise is something that has been tested or will be tested to help in the PKU diet regarding the insulin levels, because the insulin levels can affect depression and ADD.
I'm off the hook on this one.
I can answer one part of it. We do have some individuals that have PKU and have diabetes. And exercise with diabetes is definitely a good thing to do. And with our person that has PKU and diabetes, the exercise, really helps. But there's always the fear. We always have the fear with our older generation because they are putting on a lot of weight and wondering if, we're setting them up for diabetes when they get older. So it definitely is a question that everybody, I think, is looking into. But as far as having PKU and having diabetes, it definitely is manageable.
All right, and Christine tells me we have time for about 5 more minutes, so Mrs. Koch.
This is a question for Dr. Burton.
Oh, okay.
Is it possible for people to still be involved in the phase 2 of the PEG-PAL test?
Yes, there are still patients being recruited for the phase 2 study of PEG-PAL. There are multiple study centers across the United States. We have one in Chicago, Pittsburgh, Oregon, Salt Lake City, Atlanta, many different ones. Really, the patient would have to be in that center, however, to participate because it's very time intensive. There are weekly visits for a pretty long period of time, so it wouldn't be the kind of thing where, you could fly in, do it, and fly home very readily. But yes, the study is still recruiting. There are no sites in California. No.
Dr. Fox, if you weren't using healthy liver cells, but you were using stem cells, and they would convert to hepatocyte cells, would you still have the rejection issues, or is there a way that stem cells can be cloaked like the PEG-PAL molecule is cloaked to not be seen by the body?
Well, now we're getting into a lot of future issues. So my laboratory actually does do work with embryonic stem cells and inducible pluripotent stem cells, and we actually convert them into hepatocytes. The issues are, there's probably 10 years worth of work in order to make sure that they're safe. I think everybody is pretty convinced. So there are two issues in using stem cells for almost any of these diseases that are all hyped on the newspapers, and that is, number one, can you actually get the cell you want? So can you convert a stem cell into a beta cell to treat diabetes? Can you get a stem cell to be a neurologic cell that can be used to treat Parkinson's disease? Can you get a stem cell to turn into a liver cell that you can turn in that you can transplant? I think we're pretty convinced now that all of those issues are going to be solvable in a relatively short period of time. The issue is, can you get a pure supply of cells, and can you get a large number of those cells? So if you don't get a pure supply of cells, there's a chance that the cells will have a possible ability to turn into a tumor. So those issues of safety need to get resolved, and some of that stuff can't get resolved easily in animal studies because you're really not concerned about what's going to happen in a year. You're concerned about what's going to happen over the next 20 years. And I think what will happen is that we'll have to choose the patient population extremely well in order to be able to decide how to move forward in this field. The issue of whether you'll be able to get a lot of cells, I think, is another incredibly difficult issue. So we've turned stem cells and iPS cells into liver cells and transplanted them into animals. And for that, it was a tour de force to get a couple million cells. I just got done explaining that you need 1 billion cells for each patient. So you're not really talking about doubling the number. You're talking about 3 logs the number of cells to be produced just to treat one patient. I think the technology is moving incredibly fast. I think it's solvable, and I think that's going to be solved, as I said, in probably over a decade. I think the issue that nobody ever talks about is the one I talked about with cell transplantation, and the same thing is true of islet transplantation, and that is we don't know how to use stem cells even if we had them all that we wanted to. I mean, we don't get islet transplants to work indefinitely. We don't get liver cells to work indefinitely. There are a lot of issues in transplant biology that need to get worked out. I think, as I said before, we're making a lot of progress in the liver because I think we really hit on something that applies specifically to the liver, and that is the low-dose radiation liver will allow engraftment and long-term survival. Nobody's got that answer for diabetes, and nobody knows what cells or what kind of cells will work for neural transplants or muscle transplants or anything like that. Do I think this is all going to happen within the next decade? Yeah. And, I was a gene therapy person, and early on I saw that there were problems with gene therapy. I will tell you, however, that with the improvement in our understanding of transplant biology, I think that the gene therapy world is going to be coming around soon. Because people have gotten very successful. It's sort of low profile now because they've had so many difficulties with gene therapy. But there are a lot of diseases now that are being treated with gene therapy in hematopoietic stem cells and then transplantation back into patients. If you can solve the engraftment problem, we potentially can take out defective liver cells, put the corrected gene back in, and in an ability to repopulate those transplanted cells over the host cells, you could potentially expand back the corrected cells and actually cure diseases and not have to worry about any immunosuppression. But these things, I think, are coming I don't think they're as far away as they were, 20 years ago when we first started hearing about gene therapy. I can actually see light at the end of the tunnel, but I don't want to make any promises. But mostly these are technical issues.
All right, I'd like to, in sort of wrapping up, again, you've seen a broad spectrum of all the different opportunities and options that are available now to everybody affected by PKU. And so I'd like to thank all the speakers one last time for a really good session.